said it was 10 or more years ago. He said, oh, probably 14 when we talked last. And he helped me because I wasn't sure. He said, you know, when did you get this idea of bundling the meds, and weren't you the first one that did it? And indeed, he has a few provisos, but indeed he was in starting this whole concept and this whole program. And now what you're going to see is 14 years of work in how many minutes? 40 minutes, something like that. And then, of course, as we usually do, we've got the 3 questions, which we will throw up at the end, and we'll break into thirds and have each of you folks work it. But I can't tell you how pleased I am to recommend you listening very carefully to Gregg.
Do you think we should perhaps go around the room and have everybody introduce themselves?
To know, yeah. How about everybody just introduce so you know who you're talking to? Thank you.
Alan Fremont from Ramp.
I'm Jan Hirsch from the University of California, San Diego School of Pharmacy.
And I'm Grace Cole, also from UCSD School of Pharmacy.
Liz Helms, Right Care Coordinator, San Diego, and Chair of the California Chronic Care Coalition.
Mike Ruzzi, pharmacist with Arch Health.
I'm continuing from Media to Quality Management.
Scott Flynn, Medical Director, Arch Health.
Mary Ellen Leahy, Quality at Arch Health. Susan Ivey, Director of Corporate Health. Kennedy Rodley, Disease and Consultant, Medical Department, San Diego.
I'm Chuck Daniels, UCSD Health System.
Richard Butcher, Medical Director of Multicultural IPA and practicing physician with Sheridan Medical Center.
Greg Garner, Medical Director, Sharp Community Medical Group.
Jerry Maxwell, James Bookmaker, Operation for California.
Randy Moore, Integrated Patient Care Manager for Multicultural.
Rodney Hood, local physician with Multicultural. Again, we're physician with
I'm Jen Powell, Director of Competition and Health at Children's. I'm John Plummet, Director of Complete Care Management at Kaiser Permanente. Ray Bacardi, the Physician Director of Complete Care Management at Kaiser University.
Eric McDonald, I'm the Deputy Public Health Officer for the county.
Christine Gordon, I'm Vice President at UCSD. Community Eastman, I'm a physical medicine and rehab physician and I'm community medicine.
Elaine Farrell with the Council of Community Clinics.
Carolyn Gianni, technical member at UCLA and also co-PI of the NHLBI grant and co-sponsor.
Patty Hanlon, Right Care Initiative.
Well, it's a pleasure to meet all of you, and I really appreciate this invitation. So I'll be sharing my perspective on applying evidence-based therapies for preventing and treating cardiovascular disease, the role of systems in the patient-physician interaction, healthcare delivery system, and community and population level, and share some of the work we've done in this area. Here are my disclosures related to this presentation, so please do keep these in mind. So this is what we're really trying to get at, this burden of atherosclerotic vascular disease. Currently, there are about 16 million adults in the United States that have clinically manifest atherosclerosis, but many millions and millions more that have subclinical atherosclerosis. These annual event rates, although they have somewhat fallen, 1.4 million myocardial infarctions, 800,000 strokes, and every 30 seconds someone will die due to atherosclerotic-mediated cardiovascular disease. And although we have a large number of these relatively expensive cardiovascular procedures going on, patients yet continue to have events. And there's a staggering economic burden, both directly and indirectly, that comes from atherosclerotic vascular disease. So if we look at some of the leading causes of these expenditures in healthcare delivery, it is around cardiovascular disease. But much of this disease is in fact preventable, and if we were effective in implementing our evidence-based therapies, could dramatically reduce the incidence, prevalence of disease and drive down these costs. And in fact, to illustrate this, if we look at individuals presenting with atherosclerotic cardiovascular disease, we recognize that the vast majority of these individuals will have one of 4 big conventional cardiovascular risk factors present. And so hypertension, hyperlipidemia, diabetes, and smoking, about 80% of the attributable risk of atherosclerosis is right here on the big 4, and thus this is the prime target for our focus, and you will see how this plays out. Now, we have known literally for decades about the relationship between elevation in total cholesterol and LDL cholesterol and the independent risk of atherosclerotic vascular disease. You'll notice there's no abrupt cutoff or line point where you say, oh, the risk certainly begins there. It has been a continuous risk relationship. And we have had data that have evolved that have proven that lipid-lowering therapy can prevent first heart attack, prevent recurrent heart attacks. And as this data has strengthened from the clinical trials, we've had a series of national guidelines telling clinicians that they should be measuring lipid levels in individuals and, when appropriate, initiating lipid-lowering therapy through lifestyle modification and, when appropriate, through pharmacologic therapy. But yet, in this period, where all of this evidence was developed and these national guidelines came into play, if you actually looked at what was happening to cardiovascular disease after release of NCP1, NCP2, NCP3, we were seeing really modest impact. Some fall in men, relatively stable in women in this time period. Certainly if we expand the time period, there has been reduction in events, but not as large as we would expect on the basis of what had been shown in the clinical trials. So how do we explain this? Does this mean that lipid-lowering therapy doesn't really work in real-world patients as well as it does in clinical trials? Or alternatively, despite all this evidence and guidelines, were clinicians not implementing this therapy in routine clinical practice? So here's some data to actually look at it. These were high-risk patients. They all had documented coronary disease. The patient knew they had CAD. The physician was aware. The medical record clearly indicated they did. And then looking at the proportion of patients that have been treated just as minimum goal, get the LDL below 100, you can see it was only 12% of patients in this time frame. Vast majority on no lipid-lowering therapy whatsoever, and some that were on but inadequately treated. This data in over 58,000 US adults. Here was data we generated using the National Registry of MI, over 1,000 US hospitals, about 138,000 patients. They just had an acute myocardial infarction. Guidelines are crystal clear about treating these patients with lipid-lowering therapy. But you can see across the age range and sex that overall, only about a third of patients who just had an acute myocardial infarction, no question they're at high risk for events, no question that statin therapy lowers all-cause mortality in a cost-effective fashion. So no matter where we would look, even among the highest risk patients with documented CHD, there was a clear treatment gap in inpatient settings and outpatient settings, despite a very large burden of disease, large number of individuals that could benefit, that the guidelines and evidence were not being implemented routinely into clinical practice. Now, was it just that the physicians treating these patients were unaware of this evidence and guidelines, and all we needed to do was just disseminate this evidence better? But in fact, in this project at QAP, where they actually surveyed and to understand physician awareness of the NCP guidelines, in fact, 95% of the physicians surveyed said they were fully aware of the evidence and guidelines. They, in fact, were implementing them routinely in clinical practice, and in fact, they believe their patients with CHD actually were treated and were to goal. But their patients with CHD in their practice actually having LDLs below 100, only 18%. So provider awareness alone, provider belief that they're actually implementing therapy, was not sufficient to equal successful implementation. Well, maybe we just need, the leaders in cardiovascular medicine to be the treating physicians. So here are the academic medical centers involved in some of the leading cardiovascular trials, people who actually helped write the guidelines, and looking at their treatment rates well after the evidence was in, well after this was class 1 recommended in the guidelines, and look at the treatment rates for their patients with documented CHD being on any lipid-lowering therapy whatsoever. So an academic environment alone did not equal successful implementation. So what's really going on here? Well, one, we have a healthcare delivery system that is incredibly slow in implementing evidence-based therapies into routine clinical practice. So here, looking after the landmark 4S study, reduction of all-cause mortality with statins, you can see this slow adoption in practice. Now, some people would say, you know, wait long enough. Once we get 18, 20 years out, we'll eventually be up to some pretty good treatment rates, just be more patient. But others would say this is a system that clearly needs to be improved upon, and we can more rapidly implement in a routine clinical practice. So what else is behind this? Well, part of it has been what the paradigm was in a lot of this time frame about what the treatment was for coronary artery disease, where the fundamental belief was that what we were targeting was angina and ischemia. The key of treating coronary disease was revascularization. And these medications are nice if you get around to it, but not really essential therapy. And sure enough, you see a revascularization rates very high, use of anti-anginals. But as we look at those that modify the underlying disease process and truly are evidence-based and reduce heart events and clinical outcomes, much larger treatment gaps. So part of this concept behind the implementation was helping to shift the paradigm in patients with atherosclerosis or at substantial risk of not just targeting as a fundamental treatment target myocardial ischemia, where hence the key focus for treatment would be anti-anginal medications or revascularization, and risk factor modification is nice if you get around to it. But actually that atherosclerosis is the fundamental treatment target, and the combination of medications proven to be cardiovascular protective is the initial and fundamental treatment. And in fact, it is anti-anginal medications and revascularization in stable patients that is nice if you get around to it and is elective therapy, but is not initial and fundamental treatment. So needing a fundamental treatment paradigm and shift as to what the key therapeutic focus was. Now, if we were going to say, fine, we're going to target the underlying atherosclerotic disease process, what are we going to apply to these patients? Well, if you follow the newspapers, the headlines over the last couple years, all of these things shown on this slide have been touted by somebody as being a treatment for preventing or treating atherosclerotic vascular disease. So what are we supposed to do as healthcare clinicians? Try and design a system that would put our patients on every single one of these, pick what happens to be in the newspapers this week, pick what we happen to enjoy ourselves here, what should guide us? Well, fortunately, we do have prospective randomized trial definitive evidence to tell us which of these therapies sounded like a good idea, maybe had some animal models but didn't really work out, versus those that have definitively been demonstrated to reduce event risk, who have benefits that greatly exceed the risk, and where the level of evidence and standards have risen so high these can be routinely recommended in the absence of contraindications. So what are those therapies? And so in fact, what these therapies are, and they have not changed since 1994 when we first launched CHAMP, is antiplatelet therapy with aspirin, neurohormonal inhibition with beta blockers and ACE inhibitors, or alternatively now ARBs. Statins started irrespective of what that patient's baseline LDL is, and together with lifestyle modification, aerobic exercise, smoking cessation, the combination of these medications offering true benefits. And the rationale behind this is not just willy-nilly. The idea is with all of these different mechanisms that cause the initiation and propagation of atherosclerosis, the idea that you could find a single therapy that's all that patient needs really doesn't fit with the pathophysiology. And a combination of different treatments that target different components along this pathophysiologic and causative line is a better way to go to more completely impact our patients' clinical outcome. So individually, these therapies have been shown to work, but how do we know there is incremental benefit, there's cumulative benefit, it's worth utilizing the combination of medications, so-called bundling these therapies? So here's data from the 4S study. These were 4,444 individuals known CAD and included in the trial and followed for 5 years. Now, if they're not on aspirin beta blocker and unfortunate to be randomized to placebo, 29% of these individuals had an event. They were lucky to be randomized to the statin group, 20 or 40 simvastatin. This dropped markedly. But if they're on aspirin plus a statin, even further reduction, aspirin, statin, beta blocker, even greater reduction. Altogether, 3 medications, 70% reduction in major fatal and non-fatal atherosclerotic events in this patient population. And we can now look at our trials and sequences that have subsequently been done. For example, the HOPE trial looked at if you have atherosclerosis, adding an ACE inhibitor versus placebo, irrespective of blood pressure, showed 22% reduction in major cardiovascular events. And all-cause mortality, 11% reduction. But the question is, what if you're already on an aspirin? Do you need an ACE inhibitor? Yes, you see similar relative risk reduction. Already on a beta blocker, was there an additive benefit? Yes, similar relative risk reduction. Already on a statin, cumulative benefit clearly demonstrated. So the sequence of our trials also demonstrates there's a cumulative benefit, the additional benefits of adding these therapies. So the cumulative impact of our simple cardiovascular medications put together on CV death, MI, and stroke, in the absence of any of these, 20% risk, routine reduction with aspirin, with beta blocker, ACE inhibitor, or lipid-lowering therapy, and more potent lipid-lowering therapy, put together a 77% reduction in CV death, MI, and stroke, an absolute risk reduction, 15.4%, and MNT to prevent an event, a very respectable 6. So, how do we actually go about implementing therapy? Well, when we were first faced with this, we turned to the guidelines in 1993, the NCP guidelines, and this is what they told us you had to do in a patient that had documented atherosclerosis to get him initiated on lipid-lowering therapy. You were taught, oh, the lipid levels aren't stable in the hospital, or when they've just had an event, you got to wait 6 weeks. So schedule a 6-week follow-up visit, get a fasting lipid panel, obtain those lipid panel, review the results, schedule the patient for dietary counseling, prescribe a step 2 AHA diet, obtain lipid panel in 3 months, review the results, schedule the patient further dietary counseling, lipid panel 3 months later, review results, schedule and follow, finally prescribe your lipid-lowering medication. And it wasn't surprising, with each of these steps, we ended up losing a proportion of patients, and up with 20% on treatment, exactly what had been seen nationwide. So we looked at all that and said, that's not a very good system. What are we going to do about it? But we recognized there were a lot of challenges just within UCLA. Well, who are the physicians that see individuals with atherosclerosis? At the time, there were about 1,200 individual physicians in 140 different outpatient locations. And the idea of getting all these physicians in all these locations to follow all those steps seemed to be overwhelming. We wanted a better approach. But here was our budget, actually, approved by the medical center to do something about this. So we were recognizing we were resource constrained, but we did want to do something. So one of the things in looking, well, what secondary prevention therapy do patients actually get on? And this was data from the ASPIRE study, post-MI utilization. And when you look at it, hey, there was pretty good use of getting on and staying on aspirin after an event. Kind of intermediate rates of these other meds, and absolutely horrible rates with the use of lipid-lowering therapy. Well, aspirin. Patient has an event, you start it, here's the dose, continue it. Start it in hospital. So we thought, well, what if we make these other medications simpler to use, more like aspirin, and initiate it as part of their comprehensive treatment? It's so important we're going to start it prior to hospital discharge. Could we have an impact that make this the initial and fundamental treatment for these patients? So in 1994, we launched this program at UCLA we called CHAMP, Cardiovascular Hospitalization Atherosclerosis Management Program, but it was part of a broader program identifying any patient with clinically manifest atherosclerosis, and about 2 years later, we added in patients with type 2 diabetes into this. No matter how it was actually documented, they had atherosclerosis, and to start the combination of these cardiovascular protective medications as you made that diagnosis, together with counseling about lifestyle modification, and then link this as an important part of therapy, so important they weren't going to leave hospital without her, to leave that initial office visit and subsequent follow-up to making sure maintaining on therapy and getting to goals. To support implementation, this is 1994, way before systems or concepts of quality and checklists and all of this, but we created focused treatment algorithm, pre-printed order sets, discharge checklists, focused academic detailing, customized patient education material, and importantly, measuring our treatment rates and feeding it back to every single clinician that was involved in here. So creating this concept of performance improvement registry and system back in this 1994 timeframe. So here was an example of one of our pre-printed order sets with the key medications there, and making sure we were capturing patients whether coming in with chest pain, going into cath lab for acute MI, getting thrombolytics, or coming in even on medicine, which is atherosclerosis. So here's the impact. Pre-CHAMP and USOA consecutive patients who focused on the ACS population. So you can see here the use of these therapies wasn't much different than what I showed you nationwide. And after implementing therapy, the program, these really dramatic improvements in treatment rates with regards to use of therapy. Now, granted, there could have been secular trends, but we did have national data in hospitals participating in 1,400 in Germany in the same time frame. And you can see, these treatment rates were not being seen nationwide. This was a true net change occurring within our system. Now, that's at hospital discharge. So who's to say just because you started all these therapies right after patients are going to adhere to it? And we were also very aware of this data. An outpatient with documented disease started on a lipid-lowering medication. What is their persistence rate with therapy? These incredibly high discontinuation rates. Well, you can say, look, the statins were really expensive back then. I'm sure this is all cost. This is data from Canada where the medications were available to the patients at no cost whatsoever. So in the outpatient setting, you'd start on a med because you failed diet and exercise and the medication's viewed as punishment. Patients, a lot of them, stop these medications. But we were thinking, we're not starting these medications because they failed something. We're starting as the fundamental treatment for their disease and hope that patients would think this was so important. My physician wouldn't let me leave the hospital without it. This may be a therapy I want to stick with. So could we have an impact on actual medication adherence and persistence rate? So here's the 1-year data, pre-CHAMP in blue, post-CHAMP in red. And you can see really these remarkable adherence rates with the in-hospital initiation of therapy. Now you can also see it wasn't just starting meds. We were getting rid of meds we didn't think patients should routinely be on. Long-acting nitrates, calcium channel blockers, and you can also see large reductions being seen after the implementation of this. So, okay, we got the therapy started the way we wanted, and patients adhered to them. So, what happened? A lot more patients, a tenfold improvement in those getting to LDL less than 100. We're really happy about that. And I thought that was all we needed to show. But a lot of people still said, fine, you started these meds, but where's the outcome data? I'm like, what do you mean, where's the outcome data? We already have the trials that show each of these medications improve outcomes. But it became pretty clear people weren't convinced, although it worked in trials, it worked in real-world consecutive patients being treated. Were these therapies clinically effective, not just efficacious in trials? So here was our data looking at the 1-year outcomes. Pre and post-CHAMP, you can see this marked reduction, highly statistically significant recurrent MI, cutting the need for repeat hospitalization the first year by more than half, and a 53% reduction in all-cause mortality demonstrated. So real-world clinical effectiveness, implementing the evidence-based therapies, translating to improved clinical outcomes. Okay, so you did it. Is it going to be like other QI projects? You do it for your 2 years, move on to something else, treatment rates drop off. Well, here's looking at the data through 2003. We've now sustained this for 14 years, but here is the data as far as being able to maintain this and build on it further. And here was the concomitant 2002-2003 data from NERMI. So there were improvements coming on nationwide, but not to this level of routinely applying these key evidence-based therapies. So to look at this further, here's extending the data to 2010, and you can see where we implemented CHAMP at USOA. This is statin therapy at time of discharge. Very rapidly got up into sort of mid to high 80s, and then built through the 90s. And it actually was 2011, I don't have on the slide, finally got to 100%. Here is National Registry of MI. It took 3 years of arguing with them to add a little checkbox that showed lipid-lowering therapy at time of discharge, but finally did add it in 1998. We published about here, and you can see this acceleration as awareness occurred. But still a huge area under the curve. And with Get With the Guidelines CAD, at baseline was right around here, post-implementation, so teaching and non-teaching hospitals able to scale this up, get rapid improvement, and get to these very high treatment rates. Okay, so that was UCLA. Could we take this broader? So we worked with 10 hospitals in Utah, Brett James, and Intermountain Healthcare on the same type of approach done there, and you can see pre and post intervention substantial improvement. We worked with John Marinovich and Rocky Mountain Kaiser to see if we could implement the same type of approach, and you can see substantial improvement in the HMO setting. Then together with the American Heart Association, our initial pilot attempt with the guidelines built on this CHAMP model also showed improvement. In a parallel effort, Kim Eagle in Michigan led the ACC GAP program and also showed improvement in the use of therapy, and some of these also clinical outcomes. So to bridge this gap between knowledge and routine clinical practice, systems come into play here in a scalable and sustainable way to improve communication, enhance compliance, ensure the implementation of what we know we should be doing and are consensus-driven and evidence-driven from the guidelines to get that in your routine clinical practice. So, part of this concept is taking advantage of when patients are hospitalized as a teachable moment and getting key evidence-based therapies there. As we showed, the adherence to therapy is much greater when treatments start in the hospital. And the fact that they're already standardized processes, protocols, order routines, and you've got the Joint Commission, CMS, publicly reporting data, and so this is a prime target as opposed to initially going into outpatient practices, so eventually we'll need to go there. So this is from Get With The Guidelines, a web-based patient management tool with a few clicks capturing key information. But what's key here is at the bedside, clinical decision support, where you can interactively check your patient's care with the most current version of the national guideline. A key therapy missed and no contraindications, you can get started and correct that care. In addition, you can get your customized benchmark reports real time, see what your data is, drill down to individual physicians, interact with that data, and compare it to national data, similar hospitals, how you look, down to individual patients, down to males versus female, older versus younger. So this interactive ability to look at the data. In addition, patient management tool now knows all this data about patient. You can customize and report out to patients individual AHA education material for that patient. So I don't need smoking cessation counseling information if I'm a non-smoker. I don't necessarily need about hypertensive management if I'm normal-tensive, but getting this customized data. In addition, can print out an immediate discharge summary and plan for follow-up to any physician taking care of the patient, give a copy to patient, their family members, and engage patients in their care and bridge some of this discontinuity and transition of care. So a lot of key elements were all built into this kind of program. And quality metrics then have been able to be updated and involving lots of different elements of acute, subacute, and long-term prevention and use of the key evidence-based therapies in these patients. So we have more data with Get With The Guidelines showing how this works. You can get rapid improvement and then sustained over time. Importantly, you can get every bit as impact in teaching and non-teaching hospitals, large and small, all regions of the country. And in recent data, we've been able to show not just for coronary disease, but heart failure, stroke, with complex measure, you can get up to these incredibly high conformity rates that in the beginning we didn't necessarily think were possible. Here's our composite performance level at 96%. At hospitals across the country, this is looking at data on 600,000 patients hospitalized with heart failure and all nine conformance up at the 90% range. It's starting off only 6 out of 10 patients, now up at 9 out of 10. Certainly we want to be at 100% in every measure, and we're getting really close. But high-level sustained conformity through the use of this system is in fact achievable, at least in the inpatient setting. Here's data for stroke. So in the beginning, neurologists taking care of what does lipids, statins have anything to do with this? But you can see through the platform system education, getting up to these 90% treatment rates, starting off at only 30%. You say, well, how many stroke patients is this? Get With Guidelines stroke enrolls about 40% of all acute strokes in the United States. This is true population-based management. Huge impact. Look at composite performance starting at 70%, now up at 94%. So through these use of systems, sustainable over a very long period, hundreds of thousands of patients year over year deriving benefits from this kind of approach. So here's the current scope of the inpatient Get With Guidelines program. Of the 4,500 U.S. hospitals, about 2,000 unique hospitals are participating. 78% of the U.S. population's within about 20 miles of the Get With Guideline hospital, and we've got 4 million patients that have benefited from this program through. But this doesn't capture all the cardiovascular hospitalizations, so I have over half the U.S. hospitals not in one or more modules, and we need to continue to expand the scope. A little bit more about lessons from this key difference of the setting and the context in which we initiate therapy has a huge impact. Same kind of doctor, same medication, same disease state. When therapy was initiated prior to hospital discharge, viewed as part of their fundamental treatment, 90% adherence rate. Same medication, same doctor, same patient, but started on outpatient, 4 out of 10 had discontinued therapy within just the first 12 months. So context of initiating the therapy, what they're believed to do, is critically important here. And this also applies, here's beta blockers, post-MI. If not started in the hospital, highly unlikely. Even though class 1 indication, HEDIS measure, unlikely patients are started outpatient. And here for all 4 meds, when started in the hospital, much better adherence rate. When started outpatient, post-ACS, only about 1 in 5 actually get on and stay on therapy. So there is